Hi, this is Steve Sarkisian, and welcome to another episode of Glaucoma Today Journal Club. We are very happy to be joined by Constance Okeke from the Virginia Eye Consultants. And you know, Connie, I know that you've done a lot with the Trabectome. You've just written an excellent book about the Trabectome. But specifically today, we'd like to talk a little bit about the secrets to Trabectome success. You recently authored a paper in the Journal of Medicine. So tell us a little bit about some of the secrets to the Trabectome and the Trabectome success.
So the title of the book, well, thank you, Steve, for having me. I'm really happy to be here and have the opportunity to talk about the paper in the book. So the title of the paper is Trabectome Success Factors. And the idea behind the research project was to look at characteristics for success with Trabectome surgery. Having been an early MIGS adopter and understanding the importance of patient selection, it was a question that was being asked to me quite often. So in the study, we had a large group of patients, 658 patients who had Trabectome, and we looked at them over a period of a year. And these are patients who were phakic. And we looked to see what their outcomes were in terms of pressure reduction and also the number of medications reduced. And so the criteria for success was having at least a pressure reduction of 20% or more in their eye pressure, and not having any additional glaucoma surgery or need for that. So some of the interesting things that we found in the study were that of the patients who had the Trabectome surgery, as a group collectively, there was a significant reduction from baseline, which the average was about 23 millimeters of mercury, and then post at 1 year, the average was 16. So there was a significant drop across the board of the patients who had the surgery, and there was a drop in medications of about 1. When we looked in subgroup analysis of the Trabectome patients who had phaco emulsification with that surgery versus Trabectome alone, we also found some interesting things. One of the things that we found was that there was a significant drop in pressure in both groups. So whether with phaco or by Trabectome alone, it still worked well. But there was an association with a longer survival curve for the patients who had Trabectome with phaco. We saw also that there was a higher rate of need for additional glaucoma surgery in the group that had Trabectome alone. We did some regression analysis, and we were able to see some of the characteristics that showed success with Trabectome. And one was when it's combined with phaco emulsification, there is a significant greater success in the surgery, which makes sense because we knew that cataract surgery alone can be additive in terms of pressure reduction. We also saw that patients who had pseudoexfoliation did really well with the Trabectome. And this is actually something that's already been reported in other studies, but I can understand the mechanism of removal of the trabecular meshwork tissue and it being heavy laden with proteinaceous material from pseudoexfoliation, that the actual removal and then the irrigation at the same time would be helpful. So that made sense. So right now, actually, that criteria is something I heavily use clinically in all my pseudoexfoliation patients. I think of Trabectome use initially off the bat. And then we also found that in patients who had who were Hispanic, there seemed to be a additive benefit with Trabectome, which was interesting, but actually has also been reported in some other studies in the literature. That is something that needs a little bit further understanding, but something that is helpful to know. And then also we found that in the Trabectome alone group, the pressures were higher at baseline compared to the ones in the combined group. And that's understandable too, because for Trabectome alone, you're talking about reducing pressure, and that's the main reason. Versus when you're doing Trabectome phaco, they may be controlled. Maybe the idea is to try to maybe lower their pressure, but maybe try to get them off drops. And so in looking at those two groups, we did find that the higher the rate of the eye pressure, there was actually even a greater drop in IOP. And so we actually concluded that having an elevated eye pressure is actually an indication of a stronger drop in pressure. So there were actually a lot of great conclusions from the study, and these conclusions actually used practically. So I'm a very big proponent of using cataract and Trabectome surgery, but I know that doing Trabectome alone can work. and using it in patients who have pseudo exfoliation, and then in the Hispanic population.
Well, and I know in my own practice, doing the multiple different ways you can unroof a canal, unroof the TM, that really doing with cataract surgery is actually rare in my hands now. Mostly I'm doing it in pseudophakics, or like you said, younger phakic patients, because it really has a nice niche there.
Exactly.
And well, that's very exciting, and we're just so grateful that we had an opportunity to talk about this, and really congratulate you on the book. Which not only has excellent tips for trabectome, but really for all MIGS, because it goes into angle anatomy and patient selection and all those types of things, which are also very important and maybe to some not so intuitive. So it's helpful to have an opportunity to discuss those. Well, thanks again, Dr. Okeke. We really appreciate you being here. We really appreciate having the opportunity to talk about your book and also your recent publication about the trabectome and MIGS in general.
Thank you so much for having me. Pleasure.
This is Steve Sarkisian, and we just thank you for your time and look forward to seeing you for a future episode of Glaucoma Today Journal Club.